Rohit, today we have four CDK4/6 inhibitors that we tend to use commonly in our clinical practice. Three in the world of breast cancer, and one, trilaciclib, for small cell lung cancer. Today on our podcast, Oncology Brothers, we're going to focus on the ones that we use in the world of breast cancer. Hello, everyone. Thanks for joining us. I'm Rahul Gosain, here with your co host and my brother, Rohit Gosain.
Here we continue our Toxic series, a deeper dive into the side effects of CDK4/6 inhibitor and how to manage these to ensure our patients can stay on these medications safely. We will focus on three agents: ribociclib, abemaciclib, and palbociclib. We are excited to have our oncology big sister, the one who got us started, Dr. Stephanie Graff, a medical breast oncologist from Brown University Health. Stephanie, thanks so much for joining us.
Thank you so much for having me.
Stephanie, welcome. When talking about CDK4/6 inhibitors, they were initially approved for hormone receptor positive metastatic breast cancer. And in this settings, we have all three: Ribo, Palbo, Abema. But more mature data is stronger for ribociclib and abemaciclib. Because of this, the practice has changed. A lot of us are not using palbociclib heavily unless now it's with combinations like inavolisib. But more recently, based off Natalie trial and Monarchy trial, we've seen that ribociclib and abemaciclib have made their way in early breast cancer and adjuvant settings, with ribociclib having a broader inclusion criteria. Okay, so can we start here with ribo? The approved starting dose is 400 milligrams in adjuvant settings and 600 milligrams in metastatic settings. With ribociclib, we have to be careful with QTC, so we monitor EKGs. LFT, we have to be very careful with monitoring that. But we still have to keep neutropenia on our radar, as that is more of a class effect with CDK4/6 inhibitors. Stephanie, when you're talking through these options with your patients, and when it comes to ribociclib, what should be on our radar and any clinical pros on how to manage these?
Yeah, so when I talk to a patient about ribociclib versus abemaciclib in the adjuvant setting, first, I talk to patients about them early. I mentioned that this is probably going to be a part of a patient's treatment plan at our first consultation, often before surgery, because I know that the patient has a larger tumor, is node positive, has a high grade tumor, has that profile with a little bit lower ER, a little bit lower PR that makes me think that their oncotype is going to come back sky high. I'll mention, I think that you're probably going to end up on this other pill as well. Because I think that so often patients with hormone receptor positive disease think that they have good breast cancer. For anyone listening on the podcast, I'm using air quotes around the word good because I hate that. And so that I think helps patients kind of prepare that this is coming. And then in terms of choosing between ribociclib and abemaciclib, I go by the trials. There's a slightly wider group of patients that are eligible for ribociclib than abemaciclib. I try not to color outside of the lines and give abemaciclib to those lower risk patients. I engage the patient in shared decision making. I have patients who don't want to take ribociclib because they don't want a risk of liver toxicity. I have patients who had terrible diarrhea with their chemotherapy, and the idea of that being a side effect with Abema is quite concerning for them. Alternatively, they have chronic constipation and they're like, give me the Abema. And so it goes sort of every which way. We do have a press release that tells us that abemaciclib is going to be showing us overall survival data in no time at all here at the upcoming ESMO meeting. And we'll watch to see the impact of that data and how it influences these conversations. We're also going to be getting longer term follow up on Natalie
Yes.
ribociclib. But I think that what we've seen is that those curves for Natalie, although that trial accrued at a later time point, has separated at a similar pace and rate as the Abema data. We can't really do cross trial comparison. There was a lower risk population of patients. So is the impact a little bit smaller? Yes, but that's probably representative of the patient populations. I think ultimately I feel very comfortable with both drugs, and it really just comes down to what group of side effects that patient wants to feel.
Thanks for unpacking that, Stephanie. With regards to ribociclib, QTC being something that we have to worry about, do you do EKG at baseline and then 2 weeks and then start of cycle two and then forego after that?
Yeah, so when Natalie was released and the package insert got updated, regulators dropped that 2 week EKG from the package insert. Now the recommendation is a baseline EKG and then EKG in a month. I typically just do 2 EKGs. I do a careful review of their meds because I think the biggest predictor is drug interactions. And I tell patients I'm prescribing ribociclib that QT prolongation is a side effect, and the biggest predictor of that is them taking something that causes QT prolongation. Even some holistic therapies can do that. Things like grapefruit juice and St. John's wort. I encourage them that anytime they start a new medicine, they need to call and let me know so that we can watch. When we're managing things like nausea, we need to be thoughtful about what nausea medicine. If we have to reach for things like ondansetron to manage Zofran, we have to go back to checking EKGs because it can prolong
Indeed.
QT interval.
Let's talk.
Definitely talking about that. 600 milligrams is what we have for metastatic settings and 400 milligrams in adjuvant settings. Is the QTC dose dependent? And what about the LFTs?
Yeah, we certainly saw a lower rate of QT prolongation in Natalie, which leads you to think that the QT may be dose dependent. I think that the incidence of QT prolongation was so low that it's hard to say. I don't have the statistics to tell me that it's truly a dose dependent phenomenon. The fact that we saw much lower rates of QT prolongation at the 400 milligram dose compared to the 600 milligram dose, I would say yes, there's some dose dependency.
And tying in with the dose aspect as well, what we saw from phase two Emily trial is that which showed in metastatic setting, 400 milligrams of ribo was non-inferior to 600 milligrams. Stephanie, in your practice, is there a subset of patients that you feel comfortable starting at 400 milligrams rather than higher dose and then down titrating if they're having side effects?
So Amelie, the endpoint of Amelie was these sort of AEs, not clinical benefit. We've seen data that with both drugs, that patients who have dose reductions because of side effects do not have an inferior outcome. If you have an AE and you need a dose reduction, delay, hold, or modification of any sort, you don't have an inferior long-term outcome compared to patients who do not. That is very reassuring. Patients feel good knowing that they don't have to endure their terrible diarrhea because they think it's going to give them the best outcome. And that's just not okay. We should be dose reducing those patients. We have seen data that the lower dose patients have less side effects, but we haven't yet seen a head-to-head comparison that starting at that lower dose and titrating up results in the same long-term outcome. And at least academically, I can argue that if your largest cytoreduction comes with that first dose, or patients that are having toxicity are metabolically processing the drug differently and maybe more effectively in a way that's giving them that toxicity, and therefore are the patients that need to have that lower dose. The patients that need the higher dose are having a window of, I don't want to call it subtherapeutic, but less than dosing. I still tend to start at the starting dose, and I just keep the threshold low and honest about dose reduction. MASC, which is the multinational association, has a oral chemotherapy program that you can actually call patients. It's called the Oral Agent Teaching Tool, and you can download it. And it asks patients this 12-question toolkit, and what they recommend and what they've validated in some studies with different cancer centers globally. When we call patients every week for the first month, and then twice a month for month 2 and month 3, which honestly, I think with drugs like CDK4/6 inhibitors, which are pretty well tolerated, may even be more than we need to. Just do those 12 questions, which are things like, Are you taking it? Do you feel okay? What kind of side effects are you having? Patients not only have better side effect management, but they have better adherence, they have less anxiety, they feel more empowered in their care, they have a reduction in they have an improvement in their overall quality of life. And so I think that there's ways for all of us in practice to utilize our care team, our nurses, our chemo teach teams, our pharmacists, our nurse practitioners, to be connecting with our patients in a structured way that are on these oral agents without necessarily dragging them into clinic or having them have a physician visit every time. That makes sure
Absolutely.
we're appropriately addressing all their symptoms and side effects they're experiencing.
Absolutely. Again, a few things to reiterate here. It is reassuring that if we're dose reducing for side effects, we're not compromising outcomes. And then again, relying on our other team partners, nurses, nurse practitioners, nurse navigators, to make sure we're getting our patients through these medications safely. And again, in my clinical practice, between Ribo or Abema, I find that Ribo is better tolerated because of the diarrhea that comes along with Abema. And this ends up being a big quality of life issue for our patients. That said, Abema perhaps might be a little more active agent, and we've seen some data with switch therapy or a hint of activity with intracranial disease. With Abema, we have to keep diarrhea in mind. We have to keep that increased risk of VTE in mind, and again, neutropenia. When it comes to Abema, Stephanie, can you touch on some of the side effects that you worry about and how do you manage them?
With Abemaciclib, our side effects that really are concerning are diarrhea. Obviously, with everyone talks about it. We also worry about side effects like abdominal pain, decreased appetite. I think that in some ways those are actually mediated by the diarrhea itself. We can see things like fatigue. I do think that the fatigue can be a function of the diarrhea and dehydration, but it can also just be being on a CDK4/6 inhibitor and is sensitive to dose modification. Cytopenias, neutropenia, lymphopenia can happen. Thrombocytopenia and anemia are a little bit less common, but can also still happen. We still can see elevated liver function studies with abemaciclib,
Yes.
less common than we see obviously with ribociclib, where it's a bigger concern, but still a potential risk and side effect that we need to monitor for. Last but not least, the rare side effects that are serious and we worry about: a small risk of VTE, venous thromboembolism, and a small risk of interstitial pneumonitis. The risk of both of those quite low, but again, always something to sort of mention to your patients if they're having new signs or symptoms that would be concerning for that. They need to make sure that they're seeking emergency care, alerting your office depending on the particular sign or symptom.
We'll dive into the ILD pneumonitis story shortly, and this is rather a class effect which can be seen with Ribo, Abema, as well as Palbo. Sticking to the topic of diarrhea here, Stephanie, I know I'm sounding like a broken record here, but back to the dosing question. As we saw with ribociclib, if we reduce the dose, what we see is better side effect profile. Now, tying that with abemaciclib, for adjuvant settings, we often start with 150 milligrams BID, but any consideration for starting at 100 milligrams BID and then up titrating if they're tolerating the therapy well? And any role of prophylactic Imodium, or do you have it at standby and start that at the first episode when patients are experiencing diarrhea?
Yeah. So I start everyone on the starting dose and then titrate down if they're having symptoms and side effects. I do prescribe Imodium with the initial prescription so that patients have it at home. I don't necessarily have them take it prophylactically, but I am very clear that I expect them to have diarrhea and I expect them to take Imodium when they have diarrhea, not think that the diarrhea is somehow okay. The rate in Monarch E of any grade diarrhea was 83%. The chances that your patient has no diarrhea at all is really low. So
So,
I,
yep.
I just tell patients, at your first sign of diarrhea, take an Imodium. And if that doesn't make it stop, that's the point that I want you to be letting the office know, because if it persists, we may need to think about giving you extra fluids, checking your potassium, upgrading you from Imodium to Lamodal. taking a treatment break and lowering your dose. Obviously, we don't go from one episode of diarrhea to all of that, but by emphasizing with the patient that it can escalate relatively quickly. And I don't want to
Absolutely.
know on day 5 of 14 loose stools a day that this has been going on. And we've all had that experience where our patients like, I didn't want to bother you. And so they don't call and they show up hypotensive or with a really low potassium or some other symptom that you're like, oh my gosh.
Thanks for covering that, Stephanie. Diarrhea is something that impacts the quality of life significantly. It is important for us to educate our patients around this and telling them that reach out to us as we have multiple supportive medications, like as you
Yeah.
stated, Imodium or Lomotil, that can help them significantly in these settings. Okay, now moving along to our last CDK4/6 inhibitor, Palbociclib. I was using this heavily in my practice prior to the OS data. Now things have changed where the reliance is more on ribociclib and abemaciclib with AI, but palbociclib is still available with inavolisib, which is PIK3CA inhibitor. Rahul, this is another topic that we need to cover in our talks check
Oh,
discussion,
yeah.
that is PIK3CA inhibitor.
Yep.
Okay, coming back to palbociclib. Stephanie, neutropenia, fatigue, and another one that we were talking about, the class side effect is ILD or pneumonitis. When it comes to palbociclib, how do you manage some of these side effects?
Yeah, so when I prescribe any of the CDK4/6 inhibitors, I do tell patients that ILD pneumonitis is a potential side effect, that it's rare. I tell them the constellation of symptoms that I would expect ILD pneumonitis to present with, and tell them that those are things I would want to hear about, even if it's happening months after they've developed. For me, palbociclib is a medicine that I'm prescribing in the metastatic setting, if or when I'm prescribing it. As you alluded to, it is a prescription that I'm using less frequently than Ribo and Abema at this point. But with any of the CDK4/6 inhibitors, we sometimes get a CT scan and see some haziness and then be stuck wondering, oh goodness, what is this? In which case we lean, just like in the setting of Pembro, we lean a little bit on the clinical context that the patient is in, our pulmonary colleagues for things like good sputum samples, the patient's symptoms, the nature of their disease, to make our decisions on whether we think that that's a post viral symptom, disease progression, or truly a drug effect. For the most part, I would say that it's clear clinically what's happening to your patients. You either can clearly elicit a history of an infectious sign or symptom and diagnose that, or you have other evidence of disease progression that makes you suspicious that what you're seeing is lung based disease, or you're stuck thinking it's your CDK4/6 inhibitor. The management of ILD pneumonitis is the same as any other pneumonitis. I would treat it with high dose steroids and hold the drug. It is not a side effect that I have re-challenged with a CDK4/6 inhibitor. It has given me pause on whether to use other therapeutics that are associated with ILD. Patients with pre-existing ILD were excluded from trials
Yep.
in the Destiny family of trials, which is
Oh,
obviously what you're all nodding and thinking about. But trastuzumab deruxtecan is such an effective therapy that in a patient that's had a full recovery and now has clear lungs and otherwise has metastatic disease, I think I turn to that shared decision making and careful lung follow up for a patient that I would choose to treat with a different therapy, not another CDK4/6 inhibitor, and a history of a pneumonitis event. Back to side effects of Palbo, have really been the cytopenias, more profound than with the other two CDK4/6 inhibitors. That has led to really broad sweeping dose reductions. The number of patients that I was able to maintain on 125 of Palbo was quite low. Most of my patients ended up with a dose reduction relatively early in their disease course due to persistent cytopenias. I don't know if that's why we ended up seeing less of the other side effects like transaminitis, because they were never on the high
I
dose
think so.
Palbo for long.
That is
But
interesting.
otherwise, patients, once you found the right dose for their marrow to stay happy, tended to do quite well on Palbo. And I think that's still true. Just like with the other two CDK4/6 inhibitors, I still tend to start at that 125 dose and just monitor their CBC quite carefully.
And again, going back to ILD for a second here, you touched on immunotherapy, something that we're using heavily, CDK4/6 inhibitors, TDXD, of course, mortality associated. So we have to put our internist hats and rely on our pulmonologist.
Yeah.
Stephanie, I know we're well over time here, but before we close, any other supportive care strategies that should be on our radar when using CDK4/6 inhibitors or treating breast cancer patients in general?
I think it's important that we take time to listen and believe the things our patients are telling us. Often our patients tell us they're fatigued or tired, and they use different sorts of language to communicate that. It's easy for us to think, yeah, I'm tired too, and not really hear that for what it is, which is sometimes a grade 3 side
Absolutely.
effect. Sometimes patients are minimizing other symptoms like decreased appetite. We're pairing these medicines with aromatase inhibitors or fulvestrant. So patients can be having hot flashes, joint pain, and especially in the metastatic setting where they might have bony metastasis, ignore some of those side effects because we're busy and the patient in front of us may not be making a big deal out of them. But it's important to take that next step and ask those follow up questions. We all know the tips and tricks to manage the hot flashes, joint stiffness, and fatigue responds well to dose modification of the CDK4/6 inhibitor. It's just important that we take the time to hear our patients when they're saying those things.
Absolutely. I have two little ones at home, so we tell listening is important, not hearing. Stephanie, thank you so much for sharing your experience and thoughts around these available treatment options. This kind of discussion is what we hope helps our colleagues keep their patients on life prolonging therapies on for extended period of time safely. For our listeners, let's do a quick recap from today's Talk Check discussion. Today, with Dr. Stephanie Graff, we touched on the side effects and their management for three CDK4/6 inhibitors that we have available for breast cancer. Palbociclib, main concern is neutropenia, so monitoring that CBC is crucial. For ribociclib, we touched on monitoring LFTs and EKG. Whereas for Abema, managing that diarrhea and being mindful of that increased risk of VTE is critical.
And remember, the starting dose of ribociclib in adjuvant settings is 400 milligrams Q day for 3 weeks, and then 1 week off for a total of 3 years' time. And abemaciclib in adjuvant setting is 150 milligrams BID for 2 years. Thanks so much for joining us. Check out our other Talks Check episodes, treatment algorithms, and challenging case series. We are the Oncology Brothers.